If a person's kidneys become damaged by disease or injury and they're not able to properly function, they can't filter the blood still has to be cleaned. So we can do that with artificial means called dialysis, which separates the large solutes from the small ones by diffusion through a selectively permeable membrane. One method of dialysis is called hemodialysis, which directly filters the patient's blood by removing the waste products, the excess electrolytes and fluid, and then returning the cleaned up blood back into the patient's body. So the blood is removed from the body and delivered to a hemodialyzer, which is basically just an artificial kidney. Inside the hemodialyzer, the blood flows through a dialysis membrane, and it has special little pores that are large enough to permit the diffusion of small solutes. There's a special solution called the diacylate that's pumped into the dialyzer so that it surrounds the dialysis membrane. Now this dialysate is formulated to maintain diffusion gradients. Now remember, this is what the kidneys are doing, right? So those diffusion gradients allow for the removal of waste from the blood. The creatine, the urea, uric acid, phosphates, potassium, sulfate ions, but also to add back into the blood the things that we need, glucose and bicarbonate. So the cleaned blood is then going to be passed through an air embolus injector so that any air bubbles that may have been added during this filtering process can be removed from it, and then the blood's returned back to the body. Also, typically an anticoagulant like heparin is going to be added to the blood so that it doesn't clot inside the dialyzer. Most people that have to undergo hemodialysis require about 6 to 12 hours a week. However, it's usually divided into about three different sessions. Another method of dialysis is called peritoneal dialysis, and it uses the peritoneum of the abdominal cavity as the dialysis membrane to filter the blood. Now, the peritoneum, remember, lines the abdominal cavity, so it has a large surface area and a lot of blood vessels, so it's a really effective filter. So a catheter is going to be inserted into the peritoneal cavity and connected to a bag of the diacylate. Same thing that we saw with the hemodialysis. So the fluid is then going to flow into the peritoneal cavity by gravity. It's left there for a little bit of time so that permits waste products and excess electrolytes to diffuse from the blood into the diacylate. And then the diacylate is going to be drained out of the body into a bag and discarded and replaced with fresh diacylate. Urinary incontinence is when you have involuntary release of urine. Now, in infants and children, until they learn how to control urination, until they're potty trained, incontinence is normal because the neurons to the external urethral sphincter muscle are not fully developed, and that control obviously can't be exerted until the muscles are developed, the neurons are developed, and they learn to control that muscle. So normally when the bladder fills, there's a stretch reflex that stimulates urination to occur. When urinary incontinence occurs in adults, we classify it into one of 4 different types: stress, urge, overflow, and functional. So stress incontinence is the most common type, especially in young people and middle-aged females. So it results from a weakness of the deep muscles of the pelvic floor. This can be the result of vaginal childbirth and is more common to develop after multiple or repeated vaginal births, when that pushing and stretching of the pelvic floor disrupts the normal function of those muscles. But any physical stress that increases abdominal pressure, coughing, laughing, sneezing, exercise, lifting, and pregnancy can cause leakage of the urine from the urinary bladder. So something is putting stress on the muscles. Urge incontinence is more common in older people, and it's when there is an abrupt and very intense urge to urinate, followed by a loss of urine. So, involuntary urination. It can be caused by irritation of the urinary bladder wall because of infection or kidney stones, but also due to stroke or MS, spinal cord injury, because remember the micturition reflex is processed in the spinal cord, or it can simply be anxiety. Overflow incontinence is involuntary leakage of small amounts of urine caused by a blockage or weak contractions of the muscle of the bladder. So when urine flow is blocked, say there's an enlarged prostate or kidney stones, or when the urinary bladder muscles can't contract properly, the urinary bladder becomes overfilled and the pressure inside increases, and then small amounts of urine dribble out. Functional incontinence is the loss of urine from the inability just to be able to get to the toilet quickly enough. Now, this can be because stroke has impaired function. It can be severe arthritis, making it difficult to get up and to move quickly. It can be Alzheimer's disease or anything that alters mobility. So how do we treat incontinence? Well, it depends on what's causing it. Kegel exercises, which are contractions of the muscles of the pelvic floor, can help to strengthen the pelvic floor and give you more control over those muscles. Sometimes it's urinary bladder training, learning when you first feel that urge to urinate rather than waiting until the bladder has filled to a greater amount. There are medications that can help to affect the amount of urine produced. And, of course, then there is the surgical alternative as well. Diuretics are medications that slow renal absorption of water and causes diuresis or elevated urine flow. When you're producing more urine, you're decreasing blood volume. Diuretic drugs are sometimes given to patients to treat hypertension, high blood pressure, because it causes lower blood volume. This, of course, should reduce blood pressure. But there are some naturally occurring diuretics. Did you just have that cup of coffee? Well, caffeine in coffee, tea, and sodas inhibits sodium resorption, so they are diuretics. Alcohol in your beer, your mixed drinks, your wine inhibits secretion of ADH. Now remember, ADH, anti-diuretic hormone, causes us to retain water. So alcohol inhibits ADH, so we pee more. Most of these diuretic drugs are going to act by interfering with the reabsorption of the sodium. So, for example, loop diuretics, such as Lasix, selectively inhibit sodium, potassium, and chloride transporters in the ascending limb of the loop. And so what does that do? If you're not resorbing that sodium and those ions, you are urinating them out. And what do we know about sodium in water? Of course, water follows. Therefore, volume of urine increases. There are two very common blood screening tests that provide us a lot of information about how the kidneys are functioning. One of those is the BUN, B-U-N, blood urea nitrogen test, and it's going to measure blood nitrogen that is a part of the urea that results from the catabolism or breaking down of amino acids. So when glomerular filtration rate decreases severely, for instance with a renal disease or obstruction in the urinary tract, then the BUN levels in the urine rise dramatically. So one of the ways that you can treat patients that have high BUN levels in their urine is to have them minimize the amount of proteins that they take in their diet. This in turn is going to reduce the rate of the production of urea that's created when we break down proteins. Another test that can be used to evaluate kidney function is measuring plasma creatinine. The creatinine is a result of the catabolism of creatine phosphate in skeletal muscles. Think back to muscle contraction you learned in 1093 or in your Anatomy 1 class. What happened when skeletal muscle was contracting? Well, we used up our stored ATP and then we stole phosphates from creatine phosphate, right? Well, when we do so, then creatinine is the result. So when you have high levels of creatinine, plasma creatinine, then that means that hang on, let me rephrase that thought there. So the levels of the creatinine usually remain pretty steady because the rate of the excretion in the urine is usually the same as its discharge from the muscles. So when you have an increased level of creatinine, it can indicate that you have decreased renal function. An even more useful test than the BUN, the BUN, or the creatinine test that help us to evaluate how the kidneys are working is to look at how effectively the kidneys can remove something from the blood plasma. This is known as renal plasma clearance. So it's the volume of the blood that is cleaned or cleared of whatever the substance is over a period of time. High renal plasma clearance indicates efficient excretion of a substance in the urine. Low clearance means that the kidneys are not functioning properly. For example, the clearance of glucose is normally 0 because we resorb all of the glucose. So glucose shouldn't be excreted at all. Being able to know a drug's clearance is very important for determining the dosage that you give the patient. If the clearance is high, like with penicillin, then the dosage also has to be high because we're removing it very effectively from the plasma. Also, the drug will typically need to be given several times a day so that you can maintain an adequate therapeutic level in the body. If the clearance is low, then typically a lower dosage can be given because less of it is being filtered out quickly in the blood. Or I should say from the blood and into the urine for excretion. Because the prostate gland surrounds part of the urethra, any infection or enlargement or tumor can obstruct the flow of urine. Acute and chronic infections of the prostate are very common in post-pubescent, after puberty, males with inflammation of the urethra. So symptoms include fever, chills, increased frequency of urination, waking up in the middle of the night, having to go urinate, difficulty or painful urination, low back pain, maybe even blood in the urine, and painful ejaculation. Sometimes, though, there are no symptoms. Antibiotics can be used to treat most cases that are caused by a bacterial infection. However, prostate cancer is when you have tumors, mutated tissue, normal cancer, right, of the prostate gland. Now, this is the leading cause of death from cancer in men in the United States, even more than lung cancer. Each year, almost 200,000 men in the U.S. are diagnosed with prostate cancer, and about 40,000 of those will pass away from that. The amount of PSA, prostate-specific antigen, now, prostate-specific antigen, only produced by the prostate gland, so your PSA is going to increase as the prostate increases, and this could indicate an infection. It could be a simple benign enlargement of the prostate gland, or it could be prostate cancer. So blood tests can be performed to measure the levels of PSA. Males over the age of 40 should have an annual examination of the prostate gland, including a digital rectal exam, where a physician is going to palpate the gland through the rectum with their fingers. Many physicians also recommend an annual PSA test for males over the age of 50. So how do you treat prostate cancer? Well, it can involve surgery or cryotherapy, freezing, radiation, hormonal therapy, or chemotherapy. But most prostate cancers grow very slowly, so a lot of urologists will recommend watchful waiting before treating small prostatic tumors in men over the age of 70.